Okay, good afternoon, everyone. Welcome to today's Scrutiny Board for the Adults' Health and Active Lifestyles. My name is Andrew Scopes. I'm a councillor for the Beeston and Holbeck Ward and the chair of this committee. Just to let everybody know, this meeting is being webcast on the council's website and on YouTube, so you can watch it back later. Anyone who wants to see the papers we're referring to, they're available online. If you put into a good search engine, Leeds, Scrutiny, Adults' Health and Active Lifestyle, it'll probably be the first result. I'm going to start with some introductions. So as I've said already, my name is Andrew Scopes. I'm the councillor of Beeston Holbeck and the chair of this committee, and we're going to go round to my left. Thank you.
Good afternoon. I'm John Beale. I chair Health Watch Leeds and I am a co-opted member of this board.
Good afternoon, everyone. I'm Councillor Kevin Ritchie, Bramley and Stanley Ward.
Good afternoon, everyone. I'm Councillor Taylor from Chapel Allerton Ward.
Luke Farley, Labour Councillor for Bournemouth and Richmond Hill.
Hi, everyone. I'm Councillor Fiona Benner. I'm the Executive Board Member for Children's Social Care and Health Partnerships.
Good afternoon, everybody. My name is Councillor Salma Arif. I'm the Executive Member for Adult Social Care, Public Health and Active Lifestyles.
Hi everyone, Victoria Eaton, Director of Public Health, Leeds City Council.
Hello, I'm Claire Nixon. I'm the Development Manager at Forum Central and I'm deputising for Pip Goff.
Hello, I'm Tina Turnbull. I'm also from Forum Central. I'm their Workforce Advisor for the third sector.
Hello, I'm Kelly Cohen. I'm a Consultant and Clinical Director in Operations from Leeds Teaching Hospitals.
Hello, I'm Sam Prince. I'm Interim Chief Executive, Leeds Community Healthcare.
Hello, I'm Kate O'Connell. I'm Director of the Leeds Health and Care Academy and Strategic Workforce Lead.
Hi, I'm Jenny Cook. I'm the Director of Population Health Planning for the ICB team in Leeds.
Good afternoon, I'm Caroline Barrier. I'm the Interim Director for Adults and Health at Leeds City Council.
Good afternoon, I'm Helen Lewis. I'm the Director of Pathway Integration for the ICB in Leeds.
Hello everybody, I'm Councillor Winkidge for Morley South.
Good afternoon everybody, Councillor Conrad Hartbrook from Rothwell Ward.
Good afternoon, Councillor Paul Alderson, Guiseley and Rawdon Ward.
Good afternoon, everybody. I'm Councillor Caroline Anderson. I represent Adlin Wharfdale Ward.
Good afternoon. I'm Angela Brogden, Principal Scrutiny Advisor.
Super. Thank you, everyone, and welcome to today's meeting. I'm going to just hand over to Angela for the first few formal items of this meeting. Thank you.
Thank you, Chair. So under item 1, there are no appeals against the refusal of inspection of documents. Under item 2, there are no items for exclusion. In relation to item 3, there are no late items. Under item 4, please may I ask if board members have any declarations of interest? I shall take silence as none. Thank you. Under item 5, we have apologies from Councillor Gibson, and that's the only apologies relayed, Chair. Thank you.
Super, thank you very much. So I'm going to move on to the minutes next. So can you just firstly highlight the matters rising, Angela?
Thank you, Chair. So in relation to minute number 33, it's referencing the working group meeting that had been scheduled for the 27th of September. That was to discuss the issue of vaping. That had been postponed following recent developments at government level suggesting that disposable vapes are to be made illegal in the near future. So the Children and Family Scrutiny Board had received an update during its formal meeting that happened on the 4th of October and agreed that it will maintain a watching brief over the coming weeks, and that will help determine next steps. So I'll obviously keep this board informed of that. In relation to minute number 34, while board members have been provided with latest GP practice and primary care network appointment data, showing the percentage of appointments that are made within the 14-day time frame and those outside of it, we have asked the Leeds Health and Care Partnership just to provide some further clarity around what proportion of those appointments that don't occur within the 14-day timeframe are actually pre-planned. So I'll get that to members once available. And in relation to minute number 35, there was a specific request made for information on the work that's been undertaken to help reduce suicide in the particular risk group of 30 to 50-year-old men. Following this up with Public Health, we've been advised that they are actually in the process of developing the new suicide prevention action plan with partners over the coming weeks. So it's quite timely in that respect. So the plan is to actually share that with members once it is completed. Thank you, Chair.
Thank you very much. Are there any other matters arising any of the members want to raise? Can't see anyone indicating. And then are there any matters of accuracy that anyone wants to raise in the minutes? No, I'd be happy to take them as a true record. Yes, good. Thank you very much, everyone. Okay, so moving on to the first substantive item, which is health and care workforce in Leeds. I'm going to start with Councillor Bennett to do a short introduction, and then I think it would be over to Kate. Thank you.
Yeah, thank you. So this paper on workforce is an update on the workforce in the health and care sector with a particular focus on the work of the Leeds Health and Care Academy. I just wanted to pull out a couple of points. Firstly, one of the things I really welcomed on this report, and I'm sure you will too, is the focus on unpaid carers and naming them really explicitly as part of the workforce and actually a really integral part of the workforce. So the paper references the opportunities that there are for unpaid carers for training and development, and also opportunities to come into the paid workforce should they want to do that and be able to do that. I also wanted to reference, linked to that, the discussion about values-based recruitment as a really key part of addressing health inequalities, because values-based recruitment is where you're recruiting someone based on their values and their attitude rather than necessarily experience. And that's been really key in some of the initiatives we've had, which have been specifically about getting people to come into the health and care workforce who might have lacked opportunities in the past. The report also references the vulnerability of the third sector, which is really massive at the moment. And the report specifically talks about the fact that people are choosing to leave the third sector because of the current situation that we're in and the fact that it feels financially insecure. So people are leaving the third sector to go into other areas of work. Pip Goff, the director of Forum Central, raised at the Health and Wellbeing Board the vulnerability of the third sector. And as a result of that, I wrote as the chair to Tim Riley and Tom Reardon, who chair PEG, Partnership Executive Group, to ask that this was a discussion at PEG about the vulnerability of the third sector and how we ensure its viability going forward, because the third sector is a really, really key part of our workforce, and especially in reducing health inequalities. It's often the case, and I know this from my own long experience in the third sector, it's often the case that people who are in particularly marginalised groups will find it easier to access a third sector organisation than a statutory provider. So in terms of reaching into the communities that most struggle to access health and care, the third sector has a really vital role. So we need to ensure its viability going forward. Those are just the points I wanted to highlight, Chair. So I'll hand over to Kate for a more substantive overview of the paper. Thank you.
Thank you. So first of all, thank you for inviting me to come back and talk to you about the progress and the challenges that we're facing across health and social care workforce, but also some of the opportunities for progress that we've seen over the last few months. I think it's fair to say that the workforce challenges are substantive, and they are long range challenges, and certainly not unique to Leeds. Many of you will be aware that this is mirrored in many other places across the country. However, we have seen some significant changes since January, and our approach in Leeds has been very much around continuing to work together to identify what we best do together and what is best done within organisations to work around local communities, and to focus on patient and person-centred care. So our focus really, when we come together across organisations, is around integrating our health and social care workforce better so that we can realise the potential that we've got to deliver the health and wellbeing vision for Leeds. And that, as you know, is very ambitious. And part of this is around how do we really focus on person-centred approaches, working in communities and making sure that that reach that Councillor Venner spoke about there is the first step in that journey. So lots of the changes we're trying to make in Leeds are long-term. So what we're trying to track is trajectory rather than absolute outcomes, which does mean that it's challenging sometimes to see progress in the short term. However, we've got a key set of indicators which I think are now coming together quite clearly to show that progress and to reinforce the actions that are taking the biggest effect, but also to highlight those areas that are not having the impact that we want to have. And I think it's really important that we recognise both of those. So in summary, workforce capacity remains challenging across all of our employers in health and social care in Leeds. You'll see the focus today very much around third sector, but there are similar trends and patterns in other parts of the system as well. And we are very conscious that we work in quite a complex health and social care system, which actually relies quite heavily on independent delivery as well as public sector delivery. One of the biggest challenges is financial, and I think that is starting to kind of readjust itself following the COVID period, where finances and other things were obviously very focused in terms of delivery. We've seen a period over the summer where there's been a real concerted effort around tackling backlogs, waiting lists, and really trying to get into that recovery phase. However, there are some long-term challenges of COVID, which we still have to work through in terms of really understanding what the implications are from a workforce perspective. The collaborative projects that we bring together across Leeds are demonstrating some good growth and improvement, particularly highlighted in this report is the progress around jobs and employment and bringing people into the workforce. That approach very much has been a community-based approach, which is really starting to build the diversity into that option for people to enter the workforce. And you can see in there some of the figures around retention after the first year, which I wanted to highlight specifically to you, because that retention rate is actually exceeding what you would find through direct recruitment. So it's showing that the approach is actually having a longer term impact rather than just getting people into direct jobs, but are actually leading through onto careers, education and further training as well. So from an inclusive growth perspective, there are some really good indicators there. But as I say, it's a long-term approach and we're looking at evaluation and research that really kind of underpins that to make sure we can continue to refine our approach across Leeds. The focus on education and training is growing and I think is really critical. It's been supported by the release of the NHS long-term workforce plan. So really understanding what the national government's agenda is around workforce within the NHS and that long-term planning around student placements, around commissioning education, and around the growth and profile of registered professionals across the health workforce has been a really helpful development since we last attended the Scrutiny board. In Leeds, the alignment of our activities is actually quite close to what's come out with the NHS National Workforce Plan. So we think that there are opportunities that we can connect into that work to really kind of increase and accelerate the work we're doing within Leeds. But really critically, we are not going to take an NHS focused approach to the plan. We're looking at a place-based focus to the plan, which means that we're bringing social care, third sector and independent provision into that discussion right at the beginning, because this is about what we can use this for in terms of benefits for the place and our people of Leeds, not looking at it through a specific sector lens. We've got some colleagues today who've joined us from Forum Central. So Tina and Claire are here in place of Pip, who unfortunately couldn't attend, because one of the focuses for this report was very much around third sector carers, unpaid carers and volunteers, which we know are a critical part of the health and social care support infrastructure around Leeds and for individuals. But historically, they've been treated somewhat separately and certainly not supported with the same intent and the same focus as employees. Recognising the importance of their contribution and how we can best develop services and access for people of Leeds means that we have to start with the whole workforce, wherever and however they contribute. So there's been real kind of concerted effort to look at how we best work with carers and volunteers to understand their needs better. Again, there's a readjustment period post-COVID where we're seeing quite a big shift in the patterns of behaviours and engagement in volunteering and carers. And I'm sure Tina will be able to say a little bit more about that in a moment. But we see two very clear opportunities, one around training and the other one around connecting with our talent hub through the academy to really engage people and support people to do those invaluable roles effectively and well. The narrowing inequalities work is a long-term piece of work and based in local communities. This is the work that we're trying now to spread and scale up, so beyond our kind of initial ambitions around this. And I think we had a review back in February, which was just after the last board meeting, with partners to review and reassess our approach and ambition around narrowing inequalities through our workforce. The commitment was reinforced, was strengthened beyond our initial approach. So that direction of travel will enable us to connect better with carers and volunteers, and not only to develop and increase that part of our system, but to better integrate and connect with paid workforce and future careers. So Tina, I don't know if you'd like to highlight anything specific from the third sector section.
Yeah, the third sector perspective, I think, is very much the welcome that the third sector gives to opportunities for around learning and development, whether it's recruitment support, looking at the system sharing benefits, all help to support the workforce in the third sector. So that is very much welcomed. There's a couple of things to note. First of all is the importance of having really good communications when you're working with 1,000+ organisations across the city, making them all aware of what's happening and their ability to engage with that, and working with Carers Leeds on making sure that unpaid carers are aware that they can access training. That's going to be a really important thing going forwards. The fragility of the system to keep supporting that communications is it's not yet worked through about how that will be supported though. In terms of the third sector more generally, I think it's just to say that the sector is fully aware and is very pleased to note how the local authority has supported the sector on an ongoing basis and has protected the sector. So I don't know how surprised or otherwise you are to note the change in the size of the sector since just before the pandemic. And I'd draw your attention to the small copy of that of the diagrams that I put in there, and note that there's been since March 2020, there's been about a 10% reduction in organisations, according to recent research completed with Forum Central, and I believe Third Sector Leeds may well have been involved in that as well. But a 10% drop in organisations, a 34% drop in the workforce, and a 25% drop in registered volunteers. Now, even though the local authority has protected the sector to the best of its ability, I think the additive effect of both the cost of living increases, which are working out through the third sector like everywhere else, but also the increased competition nationally from national grant makers, the reductions in fundraising ability from local populations, who of course are feeling the effects of the cost of living crisis. So what that is doing is having multiple effects. So it means that third sector organisations are making cuts rather than investing. That's reducing their ability to generate funds from elsewhere. There are debates ongoing about whether contracts are renewed from other parts of the system. So all those are compounding to make that large reduction in the number of paid staff in the city. And that goes without saying about what the impact that is on our local communities, with Councillor Vella's reference about how people in areas of the city may be more inclined to have contact and get support from the third sector. The impact that has on our local communities is should be really noted. And as a city, I feel that there is a tension between the aspirations of becoming a Marmot city, of the health and well-being strategy, the words there in the strategy, and the ability of the sector to support their implementation is being really compromised. And I think it's important that the city does whatever it can to address that impact. And I think that's, would you want to add anything onto that, Claire?
I think you've covered it quite clearly, and as Councillor Benner said earlier about the vulnerability in the sector as well. I mean, there's a real opportunity in the sector because we are very active, we are really engaged with local communities, but it does require some funding. And the recent cost pressure surveys we've done, which we do every couple of months, approximately 50% of the organisations that we surveyed said that they were either at risk of closure or reducing their services. It just has quite a significant knock-on impact in the sector.
Thank you very much for that. And that's quite a stark fact just there. Recent survey, 50% of charitable organisations said they're at risk of reducing services or closing altogether. Wow. And that would have a major impact. I'm just, if you want to expand on that a bit more, I think that's really, really important.
I think a lot of charities, a lot of third sector organisations have been relying on their reserves to increase the payment for their staff, to try and retain staff. Lots of organisations have had to move away from NJC pay scales, but they're trying to do what they can to retain staff. That's not sustainable in the long term. So, and overall contracts are being reduced.
No, thank you. And I think it's clear from what's been said already, without the third sector, it's going to be a really challenging situation for people in the city. So thank you very much for that contribution. Just, Kate, on your comments, you talked about tracking the trajectory. Is there any way you could, thanks for adding in on page 18, the sort of KPIs and the achievements. I appreciate you putting that in. Is there any way you could put that in a graph so we could see how the trajectory is moving over the last 6 months and have a look at that? Obviously, you can't do that right now, but provide it later. Is that okay? Yeah, nodding. Thank you. I'm going to open up to questions if any of my board members want to ask questions. I'll start with Councillor Ritchie.
Thanks, Chair, and thank you for your presentations and contributions. 2 questions from me. Firstly, on unpaid carers, and I agree with Councillor Venner, it's welcome to see that in the paper. But I just wondered, in terms of accessing the offer of training, how will unpaid carers be supported? Because by the nature, often they can't get time off to do anything else, 100% committed to their unpaid carer role. So that's the question. What support is available so they can access the training? And then the second question is around recruitment. And I wondered if we are confident that we've got a consistent approach to recruitment in terms of reasonable adjustments at interview, because even within large organisations, you can find there are differences. It's if managers or interviewers haven't been trained, if there's not always HR support. From the comments from Claire and Tina, my suggestion, if not already, would be that Forum Central produce sort of the template for recruitment across the piece, so that reasonable adjustments taken into account, because you could be missing out on some really talented people who don't present particularly well at interview and the nature of interviews. Thank you.
Thank you. So I'm happy to pick up both of those points, and then if colleagues want to add. So I think the work around supporting carers to access learning and development is still quite early stages. So we've relatively recently launched an online learning portal, which is free at the point of access for anybody who's a carer in Leeds. So that allows people to access learning and development at their own time and pace, and with no barriers in terms of they don't have to be employed by a specific organisation to access it. So that's part of the offer. As Tina said, one of the challenges is getting awareness of that raised and making sure people know how to access it and can do that. And of course, notwithstanding some of the digital exclusion barriers that we need to consider as well. In other work that we've been doing across the academy, we've looked at what's most effective about helping people access learning and development in person and through virtual platforms as well. So we have tested a number of approaches, one of which was around providing access to grant funding, small grant funding, to allow people to backfill or provide additional caring support to free themselves up to come and undertake training. Interestingly, that wasn't very successful in terms of actually increasing numbers, but there may be a number of reasons for that, and we're still doing some analysis about why that wasn't taken up as much as we'd hoped it was. And again, some of it is about access and being aware of that as an option. But there are a number of other ways around how we take training and learning out into forums where they may be as well. So we're working with Carers Leeds to understand how we can actually take some of that learning and development out into communities better, rather than expecting people to come onto site or to do things in a more traditional way. So still early days, I think a lot to work at, but some good kind of evolving and developing ideas. And then if I pick up the second point around recruitment, we've had in Leeds, we've had the Narrowing Inequalities programme working together now across the partnership for about 3 years. And the approach through that programme is to, yes, to put in place a way to work with communities to help people access jobs through the Talent Hub, but also to put challenge back into our big statutory organisations about how they recruit and select, and actually share with them best practice and get their senior leaders on board with changing their approaches. And some of your points exactly around reasonable adjustments and building on that values-based recruitment are exactly the kinds of conversations we've been having over the last 2 or 3 years to really try and shift practice on the ground, because it's brilliant making a statement to say, we make reasonable adjustments, but it's how do you see it? How do you actually make it happen? So we've developed a number of tools to help managers do that in practice, around flexible working options, around understanding what they're permitted and able to do, but critically also connecting support, specialist support in from third sector to help individuals advocate and express what it is they need in terms of that approach. So that has started to see some really productive results. And I think that first year of retention is really testament to enabling that kind of better fit and really starting to think about how you connect an individual with a job that suits them, with the adjustments that they require, with the support they need to thrive, rather than just throwing it to an open market and saying, there's a job, you apply, good luck, because we know that that's not a fair and equitable way of doing things in a way that will support our ambition around diversity.
Super, thank you very much. Okay, I'm going to bring in Councillor Farley next.
Thank you, Chair. Now, I appreciate, obviously, you may not have had a huge amount of time to prepare following the announcement at the, I think it was a Conservative conference the other week, around the proposed abolition of T levels and A levels. Now, this follows on from the abolition of BTECs, which from responses from employers across the NHS and the care sector has had quite a profound impact on their plans for the future. What my question is what do you anticipate will be the outcome if T levels are abandoned on the employment and employability of the staff that we're recruiting across both health and care.
Thank you. Yeah, I think that is a real concern and real challenge. In terms of timescales, I understand this isn't planned to be an immediate thing, so we've got some time to work through some of the implications of that. But I think the key thing that we've seen with the introduction of T levels is the real potential that gives an alternative route for people into health and social care jobs. I think the reason that we've been successful in Leeds in growing that is the collaboration between our college and our sixth forms to really kind of work together in the interests of students and helping students access jobs at the end of it. The collaboration around placements, making sure we've got a real good diversity of placements and support, is all through that collaborative approach. So whilst I wouldn't underplay any level of disruption that a change to the kind of statutory examinations and qualifications would be, I think within Leeds we've got a good basis to adapt and adjust if we need to, and I think we've got sufficient time to plan for that. What I would say as well is we're very committed to building on the learning through T levels, A levels, and understanding that workforce planning approach from supply right the way through to entry levels and CPD and career development within both NHS and social care settings. We've also got some encouraging work within the social care settings around career frameworks, which is being discussed more and more nationally, which I think will help give us some options for how we play in qualifications. But I think critically, the approach in Leeds is that collaboration will give us a good chance of being able to adapt to it.
Thank you. So slightly different question here. It was good to note the levels of retention, especially within that first year of employment, because I think one of the things that people tend to not realise is the fact it's not necessarily the recruitment of people, but it's keeping the people that you've got within the organisations and sticking at it. So perhaps you can outline some of the practical actions that have been taken across NHS and care sectors within Leeds that have helped to improve those levels of retention.
Yes, so I think the first thing is helping individuals make an active choice in the job that they're applying for and getting experience of and a good expectation of what the reality of that job will be. So often what we find is there are quite high levels of turnover in the first year of employment because the job isn't what somebody expected it to be, or they find that the practical arrangements around getting there, covering shifts, all of those kind of things weren't clear to them, and they can't actually balance that in the way they thought they might. So I think that's the first thing, that we've made a real kind of concerted effort to put that time and effort in up front so that people can really experience what the job will be and have a better understanding. And there are so many diverse jobs in health and social care and so many opportunities that we can help direct people to explore different alternatives if one job doesn't work. So making sure that we're not just losing people because that first choice job doesn't work. Flexible working is the second big intervention that we've been really driving, and that practical support for managers to explore what the options are for flexible working. So that's flexibility in terms of hours, flexibility in terms of location, and flexibility in terms of delivery as well. So really thinking about what innovations we can use and they can use in their services to help retain people. The third area is really helping think about career progression, not just within an organisation or within a profession, but in a much more non-linear way. So lots of people will have several years of working in a particular environment, and they face the pressures and the stresses and the difficulties of that environment. And during that time, their domestic circumstances will have changed, their career ambitions will have changed. And sometimes they can't see the next step for them within their own organisation or within their own profession. So by working together across organisations, we've been able to better open up those opportunities for career coaching kind of discussions and connecting people into alternative organisations, alternative careers. And working with our universities and colleges, we can support the training to reskill and help people make those transitions in a supported way. But lots of things within organisations as well, and it's certainly not fixed. You know, there's still a lot of work to do around retention, but you know, the ambition is there, and I think we're making some good progress.
On the indulgence of the chair, one final question. Having seen obviously the what I describe as a good news story with regards to recruitment, are there any roles or specific areas within health and social care sectors where the progress hasn't been as strong in recruitment for specific roles? And if that is the case, what is being done to encourage more people into those roles?
I think probably the third sector is the place that is most vulnerable, and there is no doubt that recruitment issues are being intensified within the sector, and retention as well. So things that we're doing are included establishing the HR network within the sector, which was very much the catalyst came from within employers. The issues that the third sector deal with are like many small employers have in the city, it takes a lot of proportionate capacity to develop your approaches, particularly if you've got no HR specialist within your organisation. So the network has been really important in doing things about promoting ways to advertise, developing knowledge about the recruitment process, to practice safe recruitment, because at the bottom of this, we need to make sure that we don't let go of things like safeguarding. There's also things that we've been doing within the network that look at, if we can't address pay, then what can we do? What can we do around supporting benefits, other aspects of staff benefits? Small organisations find it very difficult to work on a benefits package. So the opportunity for system working, we've been grabbing it wherever we can. So whether that's sharing knowledge on staff discount schemes, whether it's saying it doesn't matter if you're working in a small employer, you can still engage in learning and development. But when it comes down to it, the real tension is going to be pay, and how that's continuing to fall behind statutory employers, and that feels like the elephant in the room.
Thank you. If I could come in and respond as well, certainly from an adult social care perspective, we still have considerable recruitment and retention issues with our social work workforce, both our qualified social workers and our unregistered unqualified wellbeing workers. We're operating at quite significant vacancies. That's impacting on our ability to assess the needs of people who are waiting for a social worker to come and have a conversation with them around their needs. And equally, we have got pressures around the wider social care workforce. We've been really fortunate in Leeds that we've been able to pass on to our external providers the real living wage, and for home care agencies above the real living wage, so that they can ensure that they can recruit and retain their workforce. What has happened in the last sort of 18 to 24 months as a result of those initiatives is we've seen a vast improvement in workforce retention in the wider social care workforce. This impacts, of course, on people who are going into hospital, getting people out of hospital swiftly. You'll hear shortly around the work we're doing around winter planning and around Home First programme. So it's really, really important that we keep our foot on the pedal for this one and ensure a viable market of providers. But we do also need to give some more thought to how we can attract more social work staff into Leeds to make it a really good place to come and live and work as a social worker, as part of the council's employment.
Thank you very much for that. Okay, I'm going to bring in Dr. John Beale next.
Thank you, Chair. Not so much a question, but a couple of comments. Can I first of all endorse Councillor Ritchie's comments that it's great to see that unpaid carers are certainly an integral part of that, and that's really excellent. Councillor Venner will know that the Health and Wellbeing Board members all have an ally, one of the third sector organisations that they form an allyship with, and mine happens to be Carers Leeds, and I've actually got a meeting with the Chief Exec of Carers Leeds, Claire Turner, tomorrow. If I'd been more competent and realised that so much was going to be said about Carers Leeds and unpaid carers, I would have organised it yesterday rather than tomorrow. And indeed, I did actually see her last Friday at the third sector five-a-side football competition. She was playing, but I was only spectating, I have to say. But through you, Chair, and through Angela, if Claire raises any issues with me tomorrow, I'd be very happy to feed those back and feed them back to Kate. Thank you.
Thank you. I'll take those as comments, but I think that'd be really helpful. And I think it's really positive that there's a feeling in the room about the positivity of unpaid carers. Thanks for that. Okay, I'm going to bring in Councillor Taylor next.
My thing, I'm quite happy with the report, but to retain the staff, I don't know what you have how to retain staff, because their mental health, what support do you have, what activities, weekly, not rest, but like yoga classes and things like that. It's easy, bring them in, but we have to maintain their health and well-being as well. And that's the only way I know, because I'm a previous NHS worker. So I know the stress, the pressure, and the staff. Because when I go through the door, I take everything with me. But what support have you got in place to help keep the staff?
Yes, so health and wellbeing is a really big area for collaboration across the health and care partnership. So what we've found through research is that the team environment is the most critical bit for health and well-being in terms of preventative and making sure that people have got a good environment, good relationships, access to breaks, making sure that they've got access to water, food. You know, it sounds really basic, but when people are working under such pressure, those are the kinds of things that often slip. So there's a real support from managers to make sure that they are making those provisions within their local teams, and organisations across every sector within health and care are being supported to do that through the right training and the right encouragement from their senior teams. From a collective perspective, we've invested in trying to level up access to health and wellbeing support in the more specialist environment. So we know that if you work in the NHS, you can access employee assistance programmes, similarly in the council and other large organisations. But if you work in the third sector or independent care homes or home care provision, you may well not have access to counselling and those kind of mental health support services or confidential services. So we've pooled resources to try and make that available to everybody, regardless of who your employer is. Again, we've got some challenges about getting that message out there and making sure that it's accessible to everybody and people are aware of it. So we've got more to do in terms of promoting that work. In addition, we've got some really positive contributions from our organisations who've opened their doors in terms of specialist support. So we've been working with a retreat provision, which allows people to actually go for support in a day or an afternoon, or to come together with other colleagues from across the sector. Again, it's free, it's completely subsidised. We're trying to make sure that whatever these options are, they're open to everybody. So lots going on in that space. I think some of the challenges are encouraging people to take that up, and back to the earlier point around, how do people have the time and resource and opportunity to access them. we are actually at the moment recruiting a welfare officer for health and social care workforce across Leeds, specifically focusing on small and medium-sized organisations and employers to help with that navigation. So we're hoping that we'll see an improvement with a kind of targeted engagement plan through that approach over the next few months.
I think would be great. I don't know if you've seen the advert, and encouraging school kids to talk about their homework, just to take them that second. It would be good to just give staff just a minute, just pay them to spend that 2 minutes to say, how will you just take them away from what they are doing? Because I do know how stressful it can be to attach to a patient or care for 2 hours. You just need that 2 minutes or a minute would make a big difference. And I think it would help to retain the staff, because they'll feel that you are giving them something back at work.
Thank you. I think I'll take that as a comment, if that's all right. No, thanks for that. And I think what Tina said earlier about the elephant in the room is salary. And I think that's a real challenge. And I think the council has done a really good amount of work on the wider benefit programme to help retain staff. But until you get the salary right, it's very, very difficult to get people to stay. I can't see anyone else indicating. No, so I'm going to close that item. Thank you very much. That's been really helpful, really interesting. Really appreciate you all coming and speaking to us today. Okay, we're going to move on to item 8, which is Leeds Healthcare System Resilience and Winter Planning. So resilience and winter planning. I think we're gonna. There might be just a couple of people changing seats, which is fine. Whilst they're doing that, I think Councillor Venner wants to introduce the paper. Thank you very much.
I'll just make a couple of really brief comments. So the paper highlights that we have got a really strong partnership in Leeds, and that actually there's been some really distinct improvements in relation to not only winter planning, but all year round planning, because in some ways it's felt like a never-ending winter for the last few years. But for example, there's really distinctly improved system flow and people being stuck in hospital for less days in terms of the improvements we've made in home care, for example, which is really linked to the point Caroline just made about improved pay for care workers. And that's meant we've recruited and retained care workers. And that in turn means we can get people out of hospital because there's care packages for them at home. I just wanted to highlight one issue which we discussed at the Health and Wellbeing Board 2 weeks ago. It's with regard to the vaccination programme. So it is mentioned in the report that the guidance around vaccinations has changed. We don't know why, because the actual medical guidance hasn't changed, but the target population for the autumn vaccination programme, it specifies frontline healthcare staff as one of the populations. And with previous vaccination programmes, we've vaccinated all healthcare staff, so including like admin staff, managers, and that's felt really important. And it was raised as a concern at the Health and Wellbeing Board about the fact that nationally this target had come in that was specifying frontline healthcare workers. So we did make a commitment that in Leeds we will still vaccinate all health staff. But we also agreed that as the chair of the Health and Wellbeing Board, I'd write to Dr. James Thomas, who's the medical director for the West Yorkshire Integrated Care Board, to express our concern about this, to emphasise that we're still going to vaccinate all staff in Leeds, and to seek his advice on where to escalate that concern to, because it's our view that all health and care staff should be vaccinated. I'll leave it there, Chair. Thank you.
Thank you very much. And I think Helen's going to give us a short presentation.
Hopefully seamlessly, Angela's going to put some slides up. So we'll see if that works. Otherwise, I'll just talk. Thank you so much, Chair, for inviting us back here with other colleagues who, every time we come here, we just want to be clear that this is me representing an enormous amount of work that colleagues have done, and we're just here to coordinate and just share with you some themes. And when you'll see the second slide again a little bit later. So as Councillor Venner has referenced, we have been able to make some headway in our what we've called no reason to add lost bed days, essentially the number of bed days that people spend which are not value adding to them and can cause them harm. Dr. Cohen's here as well. I'm sure she might want to add to any of that. So that's enabled us to close some of the beds that we'd had open for a very long time over COVID, which has obviously helped financial position to some extent and also means that staff are less stretched. And the patients have better outcomes. And there are other measures where we are in a better place. Caroline touched on numbers of people waiting for assessment. There are people all across the system, because not just getting people out of hospital, but then when they're in community settings, then those people going onto their permanent packages and their long-term care packages, exits out of neighbourhood teams into people's long-term solutions are as important as exits and entrances into hospital. So we have made some headway, we've made some really good progress. There's loads more to do. I would not be anyone who would pretend that we don't still have challenges on a daily basis. And those of you who experience services will know that they are still not as slick or as rapid as we would like them to be. But we have made some good progress. So we've just included a couple of other slides. These are some of the key changes. It's quite a detailed slide, but I just choose a couple of them. We've set up some more same-day primary care support to focus on respiratory conditions, particularly for children. Some of you may have seen some of that. We've seen improvement in recruitment and retention in our urgent treatment centres, which has helped some of those alternatives to A&E. We've talked a lot about the care at home and the home care market, but we've also work going on with our reablement service, the LCC reablement service, to increase its capacity. That joint work between that service and the LCH neighbourhood teams in what we've called active recovery, and you'll hear more about that probably in the final item. And that we've managed to make really good progress in reducing our dependency on people coming out of hospital into a bed. We had a significantly greater number of rehab beds than other places. We've looked to improve our length of stay in those and reduce our access to short-term home care beds, which is what we were using this time last year, to kind of maximise our capacity. We've now got better throughput through our rehab beds, our properly geared up rehab beds, which means that people are in the right place at the right time for less time, and then more people going home, and then some work on the process times, that the time it's taking for us to do some of this stuff has significantly reduced. And probably just worth mentioning, we've also some joint work with the housing team around improving our housing support and our understanding of both of mental health needs and of housing needs in the general hospital setting. We know that these are overlapping groups. It's not you've either broken your leg or you've got a severe mental illness. You can have both. And we've not been as good as we could have been historically at doing that. So more work on that. So those are some of the key service changes. Happy to answer questions about those. In terms of vaccines, Councillor Venice just touched on the vaccines. As in the first week, we were at 38% of our care home residents being vaccinated. Dawn might have a more up-to-date figure, but just the ask was to pull the dates forward, not without its challenges, since the flu vaccine has to be ordered, I think, a year in advance. So there's some tensions about whether we've been able to give flu and COVID at the same time because they changed the dates. But some really good progress on that. And as I said, Dawn or Sam, I'm sure will be happy to answer questions on those. We've referred into the report on the public health commissioned and public health supported services, recognising that health and care is not just about direct health and care, but as we've touched on throughout this presentation, it's around all of those things that keep you well in advance. So again, these are primarily LCC-led, public health-led services, but we all work in partnership in them. So the Community Infection Prevention and Control Service, which has been exceptional throughout the last 3 or 4 years, really helps us to keep on top of preventable disease and spread. The Home Plus work around independence and keeping people at home, and much more targeted this year around people at risk, trying to use a much more targeted approach to that. The Active Leeds programs, lunch clubs, and those other services that you'll be familiar with. So just to summarise really, and then happy to answer any questions, we have got additional capacity to support the health service system over winter. Much of this is about cranking up the things we are doing anyway. I think colleagues said, this is system resilience all year round. We know it will be harder in January, but we've had periods throughout the year which have been peaks and troughs. We know the beginning of November will be difficult when people come back from school. So we're aware of that full year round. So these are some of the additional services or additional capacity in existing services that we are looking to flex during the winter period. I think they are pretty much self-explanatory. The Home First programme we'll talk about a bit later. The Home Word is our new word word for the virtual ward that you'll have heard previously that Sam's colleagues run. And we've also done some more work with LTHT on remote monitoring so that people can go home 2 or 3 days earlier and be monitored at home rather than staying on a ward for some of that care. So that work is just starting with LTHT colleagues. And then we're looking at repurposing some of the beds at Dolphin Manor, which hopefully will be open before winter. The builders are there, we gather. And then you wouldn't want me to not highlight risks. So obviously the ongoing and intermittent industrial action has been enormously stressful for colleagues and enormously disruptive to some of the progress that we've been trying to make, particularly on the elective care side. Really grateful to colleagues for all the work that they've put in all our settings to make sure that we've had safe care throughout the last several weeks, but we don't know obviously how long that will continue. Pressures in primary care. I know you talked about primary care last time. I just refer you to the data which shows that we're producing more activity than we ever have done before, but it still doesn't feel sufficient. There's a risk of increased attendances to A&E, though this year it hasn't looked like that's necessarily happening. Pressures in mental health services, be remiss of me not to note those. We still see significant out of area pressures, significant length of stay and acuity in those services. Capacity and demand better on our intermediate care services, but obviously there's a risk that we try and move even faster, that may not be able to match up. We've talked about finance, both within Leeds and the cost of agency staff, and I think agency staffing costs is one of the reasons why, although we've put more money into the services, we haven't necessarily seen the productivity gains because the same amount of cost doesn't buy you as much staff. Cost of living, full poverty, workforce we've touched on, and then vaccine supply. Hopefully that one is resolved. Dawn will know the answer to that. So that's just Councillor Scopes asked me just to speak briefly. I assume you've all read the papers, so I'm happy just to take questions if that's all right. And then I might defer to my esteemed colleagues if I think they're too difficult.
Super, thank you very much. Just an opening question around, it's really good to see the number of lost bed days decreasing. I just wonder if you're also looking at data in terms of readmission data. So the risk in my head is you don't want to discharge someone too soon. Thank you.
Yes, we've included the readmission data and thank you for the prompt. It was a really important prompt. We've talked about balanced scorecards before, but we don't always remember to do them. So the readmission, the 30-day readmission rate for non-elective admissions hasn't changed materially. It's a measure that LTHT report on regularly through their board report, and we've included it in this paper. So thank you for the reminder. So we've not seen a material impact. The other area that we do look at is readmissions from our intermediate care beds, which are still, I think, higher than we would like. And I think that's the tension always between taking a risk and saying it will be a better setting for that person, but the frailty and fragility of some of those people as they leave, I think can't be underestimated. And I think it's, I remember an ENT surgeon saying to me once, I could have no readmissions, but I have an awfully full ward. And I think, you know, we know it's better for people to be in those other settings or to be at home. And you ask them, they would want to be in those places, but it's not without risk. I don't know if Kelly, you wanted to add to that, but certainly in the data, we're not seeing a huge change, which given how much of a culture change we have made over the last 3 years, I think it's really reassuring.
Yes, I can add to that. We routinely monitor readmissions across a spectrum of cohorts of patients, including patients who are on our elective waiting lists who are presenting acutely, recognising that those long waits also cause harm. We're trying to balance risk across multiple groups of patients. And as Helen says, we haven't, despite the success and despite the fact that we are, you know, as LTHC going into winter in a much better position compared to last year, which is really positive reflection of hard work across many months of transformation, we haven't seen an increase in the number of patients coming back in.
Yeah, super. Thanks for highlighting that. The graphs on page 41 of your pack, if you're interested. Okay, I'm going to bring in Councillor Hartbrook.
Thank you, Chair, and thanks for a really good report and lots of detailed information here. I've got 3 short question areas. One relating to the graph that Councillor Scopes mentioned, because it starts in March 2023, and we know that seasonality has an impact on terms of hospital demand, and I'm just curious if it was extended back to a full year, given the fact that there are lots of other pressures and seasonality to do with different weather from year to year and all the turmoil that we've had through COVID and industrial action and other factors that factor in, have we come down year on year? Because the numbers there look really, really encouraging, and it's a very, very positive news story. Your turn.
So if you go to the second part of the paper, there's an appendix which showed last year's graph. It's a very, very steep change from last year. So I think we could have, sorry, we didn't add the two graphs together, but if you go to page, do you mean the lost bed days graph?
Oh.
If you go to page, I'm so sorry, hang on one second.
46.
If you go to 46, the slide at the bottom of, sorry, if you go to the top of page 47, you'll see that over the course of the COVID, oh gosh, it's really small, isn't it? I'm so sorry. If you go to the year before, you'll see that we were regularly over 5,000 lost bed days, and it's gradually come down and then come down even more substantially over the last 12 months. So we can add them together, but no, it's not a seasonality issue. It is definitely a proper drop.
Excellent. The COVID news, and particularly vaccinating more cohorts, is good. Just wondered whether you could pass any commentary, because there's a new variant that's kicking around at the moment, how worried the NHS is, and how what the efficacy is of the current vaccine that's being dispensed.
I'm going to pass that one to my public health colleagues.
Dawn, could you just introduce yourself, because you've come to the table since
Hi, yes, my name's Dawn Bailey. I'm Chief Officer for Public Health with a remit for health protection. So to answer the question around the efficacy of the COVID vaccine, a new COVID vaccine has recently been introduced, which is a much closer alignment to the current strain. In relation to your question around how, I think it was around how the NHS is coping, was that the first question? Or whether the new variant's causing a concern. Oh, right. So the new variant is absolutely at the moment there is no evidence at the moment that there is any signs of that new variant causing any more severe illness. We're not seeing more patients becoming poorly who are being admitted into intensive care. We're keeping a really close eye on it, but at the moment, there is no concern about the new variant as it stands at the moment.
Thank you. And then lastly, before I let somebody else come in, on your last slide, you had the imbalance in demand and capacity with intermediate care. I just wondered if you could briefly expand on that.
So what we've tried to do over the last 12, 18 months is really encourage hospital staff and indeed community staff to think early about people's intermediate care needs. And you'll see throughout the work that we're going to talk about later, more people being able to go straight home or to spend less time in a bed base after they go. Obviously, what we've done is try to work as hard as we can to get as much as we can from the staff that we have, and some of the productivity gains we'll touch on later are part of that piece of work. Now, the more effective, the better we are at care planning, the better we are at taking those risks, the better we are at talking to patients and citizens about what matters to them, the more and earlier the demand is for that capacity. And there's just a tension as to whether we'll be able to maintain that rate of improvement of exit as we improve our ability to identify people early. Does that make sense? So we have put we've had some national money, and we've put some more capacity into winter, and we'll be using some more agency work over winter. There's productivity work ongoing through the active recovery team, both through the neighbourhood teams and through the skills teams, and the work that I touched on previously around productivity through our existing bed bases. But the question is, will it keep up over winter? So we've done what we can to plan for that. But I think it's just, if we lose lots of workforce through illness, or I don't know, there's another dispute that we haven't anticipated, or something untoward happens, it will be hard to manage. So we've done, I think, better planning than we've ever have done on what capacity we might need, and are closer to trying to meet that gap. But there's certainly some sub cohorts where that's really difficult. People with additional needs, people with mental health problems, people with the sorts of behaviours that make them hard to place. Capacity demand in those pathways will always be a challenge, and I don't think we've cracked that yet. So I think that's what the person who wrote the slides was referring to.
Thank you.
Great, thank you very much. Okay, I'm going to bring in Councillor Farley.
Thank you, Chair. So it's clearly positive to see so much progress has been made right across the system. Now I'm going to make a political point, which I'm not expecting you to respond to, but there is a question attached to it. So I mean, following on from the national piece of vandalism to our health and social care sectors that was the Lansley Act in 2012. We've obviously now abandoned that and moved to ICBs, ICSs, and a much more integrated approach, I think, which was always necessary for the good functioning of both health and social care, which I'm glad now the Conservatives seem to have picked up on. My question is, has this move to the ICB, ICS model impacted on the capacity and ability of the system to work more closely together? I mean, I am aware, having previously worked a million years ago across the road, that there tended to be some tension, let's say, between the health partners and the local authority, especially with regards to the use of kind of intermediate care. So has the new system helped to improve that?
I want to talk about the alliance that Leeds Community Healthcare has with adult social care, and we work tirelessly to try and form a joined up approach to all the people that we see. And so I think we probably started that 5 years ago. So I don't think it's necessarily a direct result of the ICB, but I think it's a commitment that we have between the organisations that has really joined that up. What I would say about the ICB is that the role that they have taken in terms of integrator has had a real impact on making sure that the right people are around the table discussing the right things. So I feel Leeds is in a really good place from an integration perspective, because it's about joint will to do it right.
Just to add to that as well, I think we can perhaps overstate the structural elements of integration versus the cultural elements of integration. So we're in a perpetual state of reorganization, different structures and processes that exist across health and social care. But I think what's fundamentally important across any of that structure is the relationships, the culture and their behaviours. And I guess that can withstand and has withstood in Leeds across various different structural changes that have happened over the last few years. And I guess we can anticipate to continue to happen as well.
And just to add to what already Sam and Jenny have said, I think it would be fair to say that some of our financial challenges that we're experiencing both within the council and within our NHS is also helping to ensure that we work together both at strategic level but operational as well, to make sure that we are absolutely maximising opportunities for efficiency.
Thank you. Do you have a follow-up, Councillor Farley?
I've got another question, if that's agreeable. Thank you, Chair. So I just having read through the reports, and you will accept my apologies if I've missed it. What are the omissions that I found is around the communications across the city to the wider public? Now, obviously, there's targeted letters, there's conversations taking place with what we'll describe as service users, people who are already in the system. But it's also thinking about what are we saying to the person who shows up at the emergency department with a cold, or what are we doing to promote promote that place-based care, and telling people, actually, if you've got a rash, you might be best off going to see the pharmacy first. So yeah, what can you tell me more about communications?
Yeah, so sorry, you're quite right, it's not in here. I think we've discovered over many years that telling people they're in the wrong place doesn't work very well, especially if they're already there. So a couple of things that we've done, one of which is we've worked really hard on a West Yorkshire product, particularly for children and families, which has had an enormous amount of uptake, because what we know is certainly children and families through the pandemic and before, who are lacking some of those social structures or parental structures or grandparental structures, who say, oh, it's fine, give them paracetamol, they'll be okay. We've lost a lot of that, but they've done a huge amount of work trying to encourage people into a digital space, so that there's a lot of really good health first advice, family advice, and I think we've seen some really good uptake of that. There's always an ongoing campaign everywhere around pharmacy first and some of those other things. We've got our comms team are very, very interested in proper data-driven comms, because what they said to us when we, the colleague who's now working in that space, she said, every year you produce these double-page spreads in the Yorkshire Post, but no one ever did any analysis to say, did anyone read them? Did anyone use them? Did they make any difference? So what they've done is some much more data-driven work, particularly around young adults, to say, what makes a difference? What media do they actually listen to? And some of the reasons you're probably not seeing some of that is it's been much more targeted on the populations who we know use what we might regard as inappropriate use of those settings. Not inappropriate for them, because that's their choice, but the things that we as health and care professionals would prefer them not to do. So there is ongoing work, and I can't remember which radio station it is, because obviously not one I listen to because I'm an old fogey, but so they've done some much more data-driven work to understand who is attending where, and then trying to target those comms to those places. So it may look less visible to the system, but it's an ongoing and data-driven piece of work. We have seen the A&E attendances not go up as much as we might have done. So whether that's working or whether it's something else going on, no idea. But yeah, no, there is an ongoing piece of comms and communication work. Though, as I say, I think, whether it's material, and I think the other thing is continuous communication back with practitioners about alternatives. So when we talk about Home First, and Sam may want to add things like how we work with primary care, how we work with our ambulance crews to make sure that all of those alternatives to conveyance are as real to practitioners as they are to members of the public. We've got 55,000 plus health and care staff. If they knew how to use our services, that would be an incredibly good start. So I think we're working on both parts of that equation. I don't know if colleagues wanted to add anything else on comms, Sam?
Yeah, I just think it comes back to the conversation we had last time about GP access, and people want to see a GP, but that might not be the best first line. And a friend of mine last week was telling me she'd got phoned the GP and been referred direct to a physio, and she wasn't happy about it. And my wife, who's a nurse, is saying, well, that's a great thing, but it's difficult to get that genuine belief that it is a better option, and your GP might not be the best person in every situation. I think it's the same with the A&E thing that you're making a point. But the whole
just on that, I've just seen, in fact, there's just been a comms team out right now about GP practices, and kind of the primary care team isn't necessarily the primary care team, but most GPs would say they would be much less good at musculoskeletal problems than most physios. So, but I think there is a public comms message about multi-partner teams, and we're probably not there yet. No, if that's helpful.
We're not there yet, but it's worth keep on saying it, because it's something we need to keep doing, and all of us need to do our bit. Okay, good. Okay, if you got anything else, Councillor Farley. Okay, I'm going to bring in Councillor Ritchie next.
Thank you, and thanks again for the report, which is very positive, and your contributions. Just to set the scene for this question, because I'm aware when issues come to councillors, it's when things have gone wrong. We very rarely hear when things have gone right. So the question I ask, I fully realise that the thousands of discharges that go well outweigh the handful that go wrong. But when they go wrong, it matters to the person that's involved. So I just wondered if there is a thorough inquiry when issues go wrong. And what I've found when the cases have come to me, it's around perhaps an ongoing long-term condition or disability that perhaps hasn't been taken into account. So perhaps a blind person is, put back in that house, and proper analysis of the home itself wasn't done. So that's what I'm after. Is there sort of a follow-up and a reassurance when the handful of cases that go wrong? And as I say, I know the thousands of discharges clearly go well, but if I were to tell you 100% of complaints to me, I certainly recognise it.
Yeah, completely understand that. Sam, did you want to start? And Kelly, did you want to add?
Okay, so we strive to make sure that every discharge is as good as it can be. So I'm pleased that you recognise that you hear things when they do go wrong. Things go well every day. What we try and do is have good conversations with people whilst they're in hospital, so that we can understand what their environment is at home, what any specific needs there are at home. when things do go wrong, absolutely, we have a conversation between the different organisations that are involved in that. So it might be ourselves and the Teaching Hospital Trust, it might be with the social care, it could be whoever's been involved. We do have that almost like root cause analysis. What happened here and what can we learn?
I'd just echo that really. Obviously, if any patients have come to clinical harm, then we would be doing a full investigation if that harm resulted in them coming back into hospital. And we've already seen how we monitor and oversee all readmissions within a 28-day period. I think I'd also offer the assurance that actually sometimes discharges go wrong because patients aren't getting out of hospital. And especially when we have strived to create a really individualized package of care, for us to then not meet that target is very difficult. So we also perform RCA analyses on patients where what we call a failed community discharge, where the package has been ready, but then for some reason we've not played into that in a way that has best suited our patients. So we're looking at both the patients who are coming back in who have been discharged inappropriately, but also the patients where we've missed the opportunity to get them to where they need to be.
Just also to add that a couple of years ago, we did quite a lot of work with LTHT colleagues around communication between our social care providers, so care homes, home care agencies, so that if they feel that there might have been what we call an unsafe discharge or problems once an individual has returned back to their place that they call home, then we make sure that we're having a dialogue between and we're facilitating that dialogue between the social care provider and our hospital discharge staff.
Thank you. And there's the PALS system, isn't there, where you can put in a complaint. And my one experience of failed discharge was through the PALS system, and they were very thorough in the investigation. And so that was reassuring to the person, relatives. Do you want to comment on that? Sorry, Helen.
Yeah, no, thanks. That's really helpful. I mean, I do think that we can always learn, and we always would strive to learn. So I think, I mean, I know that you will see those probably more than we do, but I do think encouraging people to feed that stuff back in. I also have, we all have personal discharge stories, and they always give us something to learn from. So they may not be unsafe, but they may not be optimal. So, I think we do strive to learn from them. But yeah, I mean, I would be clearly not every discharge is perfect. Not everything is perfect. So really helpful feedback. Thank you so much.
Thank you. Okay, Dr. John Beale.
Thank you, Chair. Just a quick question. I've had, in fact, both COVID and flu vaccine just last week. And I was very happy to have them both. In fact, I was booked for the COVID vaccination, and when I got there said, can I have the flu vaccine as well, and got it. But I do understand that there are some clinicians, not in Leeds as far as I know, who are reluctant to give both at the same time on the basis that if there is any reaction, it's difficult to tell which one the reaction is to. I just wondered if there's any clinical guidelines on that.
Certainly, obviously in Leeds we follow those clinical guidelines really closely, and at the moment the advice very much is to give COVID and flu if clinically advised for that situation, for that case, definitely. But there may be circumstances with individual cases where it might not be advised.
Great, thank you very much. I can't see anyone else indicating to ask a question. So I forgot to say at the start, thank you very much, Helen, for adding the extra data that I asked for into the paper. I thought that's really helpful, and it sort of was picked up by Councillor Hartbrook and others. So it's perfect to have it in there. So thank you for that. Thanks for coming today. Really appreciate your time. And we're going to move on to item 9 now. So the Home First programme. I'll just give people a chance to move seats. I think we normally have a 5-minute break at this point because it's nearly 3 o'clock. So I think we're going to do that as per normal, as a comfort break, and let people change seats, and then we'll come back. But please be back here really, really promptly so we can start promptly. Thank you. Okay, welcome back to the Scrutiny Board today. We're moving on to item 9, which is the Home First programme. I'm really excited about this coming to the board. And so I'm going to hand over, I think, to Jenny first. Do you want to comment? Councillor Salma Arif first. Thank you.
Thank you, Chair. Just some words from me. So, Chair, we recognise that our intermediate care arrangements and the pathways in and out of the range of services are not always timely or efficient, and we can do more to prevent avoidable hospital admissions. We also know that we should and can use data more effectively to improve people's experiences of the healthcare system. In recognising the size and the scale of the challenges, last year we engaged Newton as a transformation partner to help us make the required changes to improve these pathways and services. And like you, I'm also excited about the Home First programme, which is a hugely important programme spanning 2 to 3 years, aimed at improving the effectiveness of our intermediate care tier and ensuring improved outcomes for people who need support to remain living well at their home or help them in recovery after a stay in hospital. I'll now pass over to colleagues who are involved in leading the programme to provide a further update. Thank you.
Thanks for that introduction. So Megan's just joined us. So Megan Rowlands is the programme director on the Home First programme, and she's going to speak in a moment and talk through a couple of pieces. But this is a genuine team leads programme of work. If you were to just have a snapshot of the team that are doing on this, you'll find people from adult social care, from the hospital, from the community trust, from our third sector providers, all working together on this really important programme of work. I'm not going to repeat what's in the paper, but I've got a few slides just around some specific areas. The paper's kind of in 3 parts. So you've got some background to the programme itself, then some of the kind of recent wins and achievements that we've had in the programme, and then a bit of a deep dive into each of the project areas in a bit more detail. If we can just pop the slides up, I'm just going to talk through these bits. So the first slide, the main slide, which is if you ever hear us talking about Home First again, you will always see this slide because it's our North Star. Effectively, it's the real outcomes that we're looking to achieve in the programme. But what I want to do, just break that down in a bit more detail and show some of the trajectories around how we're going to achieve these outcomes over the course of the programme and kind of by when, because we've obviously just had a focus on winter and a really important discussion on winter resilience. And the Home First programme, as you've heard, has played into that winter resilience piece. But what's really important is this is not a short-term winter programme, it's a long-term transformation programme. And so it's really intentionally, some of the gains that we'll see will not start to actually materialise perhaps until the spring and the summer of next year. And that's partly because with all the pressures that we've had over the last few winters, one of the things the system has done, kind of rightly so, is add in additional services, layer in additional capacity. And that's created quite a complex set of arrangements that now the Home First programme is looking to kind of gradually unpick and simplify over time. So if we just move on, please. I think you've got a copy of some of these as well, because it's not the biggest font to read. But what you'll see on this first page is, like I say, some of the outcomes broken down by project area. And under transfers of care, you got those kind of trajectories around acute discharges home, around acute discharges into long-term beds, and that no reason to reside number that we've come back to. And there's our indication of the Home First programme working. If we can have more people going directly home and less people going into long-term beds overall, we know that that's better for people's independence and their long-term outcomes. For active recovery, we're tracking both the active recovery effectiveness and the number of people starting in our active recovery services. And you can see the kind of dotted line is our trajectory of improvements, and then the kind of forecast range, because obviously it's kind of never precise, these things, and we're working within a range, and all of that takes into account the kind of expected seasonality and increases in demand over winter as well. If we move on to the next one, please. And then we've got our rehab and recovery beds. So a big element of the programme is reducing the length of stay, so the length of time that people spend in those community care beds, so they get the reablement that they need, and then they're able to go into their own beds as soon as possible. We've already seen some really significant gains there, as outlined in the paper, and as a result we're able to reduce our spot purchasing of beds and actually close some of our beds going into next year as well. So that's freeing up resource in the system as well. And again, a key focus on people going home after their spell in the rehab and recovery beds. And then the last one is around our admissions avoidance work and our anticipated benefits around admissions avoidance. So that just gives you a sense, I guess, of the program itself and the time frame when we expect to see some of these benefits go through, because when you look at those headline numbers, they're big numbers, and it's important to kind of break that down and what the projects are looking to achieve. The other bit we wanted to touch on before we open up into questions was I'm going to ask Megan to talk through a couple of, just bring to light some of the pilot work that's underway, what's actually happening, and some of the benefits again that we've seen, because there's lots of detail in that paper and we kind of touch on these pilots, but actually for each one of these areas of work, they involve lots of different teams and some really great learning throughout the process as well. Oh, and sorry, the last thing to say, sorry, before I pass on to Megan, was just to say that all of these trajectories currently are out to July 24, and that's, I guess, the next phase of the programme is really focused on between now and next summer. That doesn't necessarily mean that's the end and we're done and intermediate care is kind of perfect at that point, but that's this phase of work, and there's still a lot more to do as a partnership around our even longer term aims around more integrated provision and even further improving outcomes for people in Leeds. So Megan, over to you to talk through some of those pilot areas.
Afternoon, everybody. So I'm Megan, Programme Director, as Jenny said, for this work, working with lots and lots of colleagues and our colleagues within Newton, as Councillor Arafat said. So on this slide, we thought we'd drill down even further to show how some of the work that's in progress at the moment is already starting to have an impact ahead of this winter. So the next couple of slides sort of take us into the pilot work that's going on in the transfers of care projects. So this slide comes from J32, which is one of the wards at St James's Hospital, where we support people who are no longer have a medical reason to be in hospital, are ready to go home and move on to or move on to their next step in their care. So since our trial started here in the middle of August, we've seen an increase in the number of people who've been discharged home each week above our target level. And really importantly, an increase in the proportion of people who are going home, either with formal support or indeed going home with informal support from family carers and other support mechanisms that they've got in place. We've also seen a reduction in length of stay for people who are medically optimised for discharge. So that top right graph here shows that, and that obviously means that people are at home, which is generally where they want to be, or in a place of care that's closer to their home. But obviously critically that we've also freed up that hospital bed, and that means that can be used to support somebody else who needs it. So that's where we're up to with our J32 work at the moment. On the next slide, we've got the similar results for J16. So J16 is also one of the wards at St James's Hospital, where that's an acute medical ward, so a much more diverse range of needs within that ward, including people who are continuing to have their acute medical hospital-based care needs met. Again, you can see some encouraging results since we started our pilot there in August, an increase in the number of people being supported on a more independent pathway, so fewer people on pathway 3, which is people who are being supported through our social work and social care, more complex care needs, which links to a point Caroline was making earlier about how we work with our available social work capacity. And an increase in people being supported on more independent pathways, so pathway 0, which is home without formal support, pathway 1, home with support, and some people being supported on pathway 2, which is the short-term beds where we support people with ongoing rehabilitation and assessments. Interestingly, in the bottom left, you can see initial very encouraging results as we put in place a range of interventions which are detailed in the paper, but then you can see for the last couple of weeks we've seen a drop-off in the number of discharges each week, and that's been associated with a number of things. We've had the industrial action, as Helen mentioned earlier, and that's particularly affected the number of people who are being supported to achieve that medically optimised for discharge points, but it's also impacted on staff working in that setting, so people are needing to focus on a number of different things at that point with the industrial action in place, and that ward also experienced some COVID, which again impacted on the number of discharges. So you can see that the system we're working in has got lots of different factors, as I think Helen's report highlighted earlier. And then our final slide takes us into the active recovery at home work, which is where we're bringing together the skills reablement service from Leeds City Council and the neighbourhood team offer from Leeds Community Healthcare. And this pilot's operating in Seacroft, neighbourhood team, and Eastby skills reablement team. Our baseline target here was we started off with a baseline of 4 per week people being supported through reablement, and we've exceeded that every week except for one, which was the bank holiday week at the end of August. You can see the mixture here of reablement starts, joint starts, and starts supported by neighbourhood team alone. And that element of joint working is really key to support people's most effective rehabilitation and recovery. The numbers here look relatively small, but I think, as Jenny said, they aggregate up over time. So if we're able to progress with this work and it continues in a positive way over time, as we get to roll out across the city, we'll be able to achieve those large numbers that are in that initial target that we're working towards. Thanks very much.
Thank you very much for that. That's really positive. And just an initial question around sort of the monitoring of the programme. So obviously the data we have here looks very good. I guess is it your role to keep monitoring the data as we go through the programme? And I guess what are your escalation points if we're not achieving the hoped outcomes?
Yes, there's multiple layers. So day to day, Megan runs the programme, holds the programme team to account, and we'll be looking at the how the programme is achieving its objectives. We also have a programme board that has that more formal accountability structure, and both Caroline and Sam are members of that programme board, and it's their role to kind of hold the programme team to account also. And that programme board also reports into our partnership executive group as well. So there's kind of multiple layers of assurance and accountability. Furthermore, the system visibility dashboard, which you can see, the snapshot of that in the paper, provides not just accountability for the programme, but a better day-to-day sense of what's happening in the system right now. So it has those benefits on a more operational basis as well.
Thank you very much. Are there questions from other members? Yeah, Councillor Kidger.
Can I ask what percentage of people go out without any care? Do you ever release them out without care at home? Because I have heard this quite a lot in my area.
Well, lots of people don't need any ongoing care or don't need any statutory care, so it's a significant proportion. So most people, people who go in and out of hospital don't need care at all. So a lot of our elective patients don't need any care. A lot of people who didn't have care before. If there are, I think it goes back to Councillor's concern before, if there are people who need care who haven't got it, then we've got our assessment and our discussion with the patient wrong. So the vast majority of people leave hospital without any formal care. But this programme specifically around those people who might need care and making sure that we get the right care for them.
So you would if somebody went home and they didn't have the care, you would instigate the care package.
So I think it depends on the question. If it's someone who needed care, got home and found they couldn't manage, then A, we've done a care planning wrong in the hospital, and B, then we would need to work out how we pick that up rapidly through our community services, which would usually be, I think, back through the GP and back through our urgent community response. If there are people who didn't need, there are many, what I was trying to say was there are lots of people who don't need care on discharge. Usually people who are well before they come in don't need. Do you want to elaborate the question?
Would you then you know, do you ever get people who I don't want a package, and you know, how do you, although they could do with a package, how do you work that then, please?
I mean, I can answer that from a hospital perspective. 85% of our patients don't have any packages of care, so they are what we call pathway zero discharges. They come in and they're going home and they're well. But it's relatively common for us to come in and either their illness or the reason they've come in has meant that they struggle to manage a little bit. And they need something temporary, or we identify problems that possibly have been going on for a long time at home and have perhaps gone under the radar. And obviously from our perspective, it's about patient safety. But trying to balance that with choice can sometimes be difficult, and we have to work together with the patient and their partner and their families to get to the position, to try to get them back to home as quickly and as safely as we can. It's very rare that there's a huge amount of conflict about that. We can normally all work together, both inside and outside the hospital, to get to a package that the patients kind of appreciate and will be able to, will kind of, is something that fits with them and their values. It's very rare that we have to involve kind of formal safeguarding to overrule a patient's wishes, if that's what you're asking about.
Thank you.
Thank you. Okay, I'm going to bring in Councillor Ritchie next.
Thank you. Thanks for your presentation. The active recovery at home pilot, have we got capacity within our council reablement team, which, by the way, I have had some really positive feedback over the years about how great that has been. Then the negative comes when it moves on to a care package, but that's historic. So have we got the capacity to, I'm not sure if it's not clear, if I might have missed it, forgive me, if it's a citywide pilot this, or if it's a short-term pilot. So that's question one, and then I'll come back with another question if that's all right.
Thank you. Yes, so the pilot is starting in one of our localities, local areas. The intention is for it to be rolled out to the other reablement teams. So it's pilot testing the principles, and then hopefully, if proved successful, rolling it out. In terms of your question about capacity, I have to be honest with you, that is an issue for us. We are still running below maximum capacity of what our provision should be, the size of our reablement service, because we've got something in the region of about 26% staff vacancies within our skills reablement service, staff that are support workers, and we are constantly on a rolling programme of recruitment so that we can attract the workforce to provide the capacity that the whole service is initially set up for. So yes, it's not there yet, but we continue to work on it.
And just to add to that, from the work we're doing within the pilot, one of the things we're really focused on is making the most impact with the capacity we do have. So as part of our work, we're looking at how we address the processes that sometimes get in the way of moving people smoothly onto their next step in their care, so that the capacity we do have, as Caroline says, we can really make the most impact with that to support independence.
The second question is more of a technical one, which is probably down to me and my way of thinking. This financial saving of 17 to 23 million pound, which sounds very impressive, but even without that, it's an impressive piece of work. Is that a saving to the NHS? That's one question. And the second question is it actually a cash saving? Because in most cases, you will move people from hospital to home, but there's so many people waiting, those beds are still going to be at capacity. So, as I say, that's my line of thinking, which is probably a bit strange to some, but hey ho.
No, we get that question regularly, so definitely not. The savings are across health and social care. So there are savings for the local authority as part of this, particularly related to reducing those longer term care packages or longer term residential care, which is very, very costly. So there's kind of benefits for almost every partner in this system from a financial perspective. And there is a real divide between, so some of those things are incredibly cashable savings. So for example, I alluded to the fact that we're able to reduce our number of spot purchase beds and community care beds that we have in Leeds. Now that's, they're not NHS providers in some instances. And so that is a very cashable saving that doesn't have a stranded cost for the health system. And so we're able to really, I guess, bank those savings. Some of the savings, though, as you'd say, are not as cashable in the same way. So for example, capacity that we might free up in the hospital, in some cases we have been able to close those wards, and that is a saving. But sometimes that capacity might be used for other things such as elective recovery, or we might need that capacity differently. So they they have different kind of cashability, those different elements, but they are all kind of tracked and monitored on a really regular basis, because this is what the system has signed up to overall.
And I can just add to that. So, I mean, these are very much cash releasing for the trust. So when we have, lots and lots of patients last year who are medically ready to leave, then at our peak, we had 7 wards open, and a lot of those wards wouldn't normally be open. So being able to, this transformative work has helped us to close 2 wards without any impact on the rest of our patients and our acute and elective capacity. So it absolutely does turn into money from our perspective, which is obviously a very welcome outcome.
Thank you. And from an adult social care perspective, Jenny's already mentioned that certainly over the last winter, we were using so many short-term beds from the independent sector at a higher rate than we would pay our agreed framework rates. By reducing that in itself is a direct saving, but also our savings within adult social care are predicated on reducing the number of people that end up in a long-term care home, probably too early, much earlier than they should, by allowing more or enabling more people to go into one of the rehab and recovery beds for a short period of time, with the ultimate aim of going home with a home care package, which will cost a lot less than a long-term care home placement. So, and it's completely a better outcome for our local residents as well, majority of who absolutely want to go home. So there will be very clear identified cashable savings to the Adult Social Care Directorate too.
Thank you for that. That's very helpful. And yeah, I could see some of the obvious cashable savings. So that figure then, again, for accuracy, is that fair to say that that is the cashable saving across the sector, or could it be a mixture of both?
Yes and no. So I'm not being intentionally evasive, but some of that, I guess, is a bit of a policy question for individual organisations about how they then choose to use that capacity. So, like, will we achieve these financial benefits? Yes, as a programme, and that is very clear, very measurable. But, for example, should then the trust, the hospital, decide to redeploy that capacity in a different way, that's almost a separate decision that's slightly separate from the programme itself. So they may choose to be able to close those wards, cash that financial benefit, or it may be that that is redeployed in a different way. So I think it depends organisationally on the policy decision that's made on the back of the savings that are made. But what we can say is that a significant amount of that value will be like genuine real savings to the health and care system overall.
Thank you very much for that really clear answer, actually. Okay, I'm going to bring in Dr. John Beale next.
Thank you, Chair. It's a very interesting scheme, and it seems to be moving in the right direction from the point of view of the NHS and social care. My question is, what evaluation are you doing to see if it is a good scheme according to the experience of the patients? In other words, there are a range of questions you could ask which show that they're pleased that early on in their treatment, the hospital is starting to talk to them about what are you going to do when you go home, when you're better, what are your needs going to be, what support will you need. On the other hand, and I suspect it wouldn't be true from what I know about it, but it could be that they feel they're being hassled. The hospital is just trying to get rid of them as soon as possible and sending them out with the support they need. Are you building in that sort of evaluation?
Thanks for the question. So a couple of different things to mention. So first of all, when we started this work right at the beginning, we undertook a diagnostic exercise, and a really important part of that was understanding the experience of people in our system and how they work through our system, and what was working well and what could have been better. The Health Watch report around hospital discharge was a really key part of that, and that set out 3 really key things for us to look at, which was compassion, communication and coordination, all of which are absolutely part of this programme. So it kind of started before we started the programme, that kind of how voices of people were influencing our work. And we then translated those into what we've called I statements, so statements representing the perspectives of people and family and carers about what matters to people and how that is influencing the design of what we're working on. So that's a key part of it. We've just recently completed our first baseline round of patient reported experience measures in a number of the key existing services that are part of this work. So we've got that baseline which showed overall a really positive experience for people accessing services, but also some key things for us to keep working on. And in particular, there was a key finding there around supporting people with really specific goals and what mattered to them, and a bit more work we need to do on focusing on that, which we'll then put into our next phase of work. And the last thing I was going to mention was when we're doing the work and the sort of testing of change, feedback from people is a really important part of that. So whether that's the people who we're working with in the services and kind of how it feels to be in a rehab and recovery bed and using our new goal setting approach, and equally from our staff who are part of delivering that. So we're working with people in the design bit of and sort of how it's working in practice and using that feedback to inform the next phase. So we'll repeat that experience measure periodically through the programme and be able to report on that as well.
Yes, thanks very much, Chair. Hopefully we'll be able to see some of the results of that evaluation in due course.
Thank you. I was just going to say we need to put it as an action point to see that, because I think you're absolutely really spot on there with that question. So thank you for that, Doctor. Okay, I'm going to bring in Councillor Farley next.
Thank you, Chair. Just looking at the report, I mean, I think this is I think this scheme is clearly a positive for patients. Nobody wants to spend longer than they have to in a hospital environment, and I appreciate kind of there's been various iterations of schemes like this over the years, so it's good to see all of the evidence. I suppose my question really focuses on readmission, because we're currently circling around 10% in terms of the readmissions within 30 days. Do we have any data on these patients? You know, are they coming in with you know, I don't know, with a urinary infection and then leaving and then coming back with a broken leg, i.e. kind of unrelated ailments, or are they coming back with the same or similar issues? Do we have any information on that?
So we know when we do thematic analyses of our readmission or readmitted patients, the majority of them will be readmitted with a complication of the first thing that they went into hospital with. That's often things like post-operative infections and, you know, complications of their initial condition. We also see readmissions in patients who are very frail and vulnerable at home, irrespective often of the package of care that's being provided. It's that, you know, some of our patients just, especially as they're approaching that kind of final 1,000 days, which is the kind of the age range, or those patients who are approaching the end of life sometimes, who are very frail, very vulnerable. The pattern is often of repeated admissions, despite us doing our best to get them home. And obviously, ultimately, those patients will often end up in more full-time care because of these kind of escalations that we see. So it's a mixture, and it's what we do know is that it's infrequently related to kind of inadequate care. It's just that the patient's care needs are accelerating and escalating kind of faster, I guess, than the system than we expect.
Thank you. I've had one more point. I've now got two more points because you've sort of inspired a question, a slightly morbid question, perhaps. Firstly, you know, that 10% is currently feels relatively steady, but what efforts, if any, have been made to reduce that? And I understand obviously the context of you know, nobody's getting any younger, regrettably. But are there any interventions that could be made or that have been looked at to reduce that readmission rate? And the second point, and you know, again, perhaps slightly more morbidly, does this scheme tie in with palliative care, and does it accommodate those people who might be who might be overcoming their particular illness and then thinking, well, actually, I might not have long left. So that in and of itself becoming the care package, if you understand, or is that a completely separate issue?
They probably are quite separate. So just on the first point around what are we doing to prevent readmissions? I mean, the causes of readmissions are multiple and varied, but that it's the whole gamut of responses, from following best practice around coming in, having an operation and going home again, how we use antibiotics, how we prevent straightforward things like wound infections and water infections after people have been in hospital, which is a relatively common cause of people coming back in for a checkup and needing antibiotics, etc., all the way through to trying to make our discharges as safe as possible by working with our transfer of care hub, by having that integration between all the teams so that the patient gets the right package first time and that we're not sending them home into a potentially unsafe environment. So we're constantly monitoring and re-monitoring that and feeding back the themes, but there's huge possible underlying reasons why a patient might come into hospital. In terms of the palliative care, so we have really well established pathways that are fast tracked for patients who are recognised to be approaching the active stage of the end of their life. We try to keep that separate as much as we can, because obviously those patients and families need very kind of concentrated, specific and individualised care packages. Not that everybody doesn't get that, but those things need to be in place very, very quickly, and we pull out all the stops to try to get patients back to their preferred place of death when we can. And Helen, I don't know if you want to add to that.
Yeah, I would think the other thing that we haven't touched on as much as maybe we could have done, and I'm sure Sam will want to speak to it, is around our urgent community response and how ultimately our ambition is for more of these people to not be admitted and then discharged on an intermediate care plan, but actually admission avoidance is as important to us in terms of step up. And I think what we're finding is if you've potentially been home with one of our virtual ward officers, then you're then known to that team. Just talked to a colleague in Wakeford, she said 50% of her patients now are admission avoidance in that space because they're now known to the team, they know the team, they've got the team's phone number, and that actually then they are less scared about not going into hospital for their next acute episode and more safe and able to be managed in their own homes. So for some people, and that would definitely not be right for everybody, our ability to do enhanced care at home then hopefully over the next few years then becomes more embedded in our practice. But I think people are quite anxious about it because nobody wants to be seen to be denying someone best care. And so if best care is always hospital, then you don't want to deny them that. Once you've come home with supported care with experts in community, then you begin to understand that that is also for some things optimal care, and therefore you're going to be much less anxious next time when the GP says, oh, shall I try the virtual ward? You have a whole cultural build up, and our work with general practice in particular, but Yaz as well, is about saying where are there safe alternatives. And the other work that we're doing with the same day emergency care teams at the hospital is, instead of admitting someone overnight that then turns into 2 nights and turns into 3 nights, what are the diagnostics that we can do to assure ourselves that that person probably could be safely cared for at home, and then relatively quickly get them home, rather than doing what we might have done before, which is to go, well, we'll just give them a couple of days and see how we go. We know that those couple of days are not necessarily beneficial. And so there's much, I think, closer cultural working between those same days emergency colleagues seeing themselves as part of a community offer rather than seeing themselves as a barrier to hospital offer. And I think that's a cultural shift that we've seen. When Jenny talked a lot about culture, a lot of this is about culture. Sam, did you want to add anything more about admission avoidance? I'm just conscious we haven't talked maybe as much about it as we could have done.
I think you've covered it actually, but we're really promoting the opportunity for people to be cared for at home, and we have spent quite a lot of time going out to general practice to talk about, consider this as an opportunity rather than referring to hospital. And we have seen a turnaround in that people who were presenting at ED are actually being cared for at home. So we have a very rapid response. We try to be there within 2 hours. So that feels to people as if they get as urgent a response at home as they would had they gone to hospital.
Follow-up question.
It's more of a suggestion. Obviously we've in a lot of these sessions we've discussed virtual wards, and perhaps it would be perhaps we could look at a session like just exploring, what exactly does a virtual ward entail? What is the experience of the service user, of the patient? Because I think quite a lot of the time we have these conversations that is somewhat detached from, or we have no experience or context for the reality of what does this look like for a patient? Perhaps not a formal session, perhaps just something we could look at for the future. Thank you.
Yeah, thanks for that, Councillor Farley. I can see nods from our colleagues, so I'm sure we'll be able to arrange that. I think an informal session might be really helpful, and something around maybe seeing some of the kit you have. Obviously, we can't go to someone's house and see their virtual ward, but it might be interesting to see understand what sort of things you're doing. So that'd be really appreciated. Okay, I'm going to move on to Councillor Hartbrook next. Thank you.
Thank you, Chair. Something that you said earlier on about the final 1,000 days really resonated with me, because I've just come through that with my own mother right the way to the end. And I just want to say thank you to the staff, well, right the way across the NHS in Leeds, but J15, J28 and the many other Js where patients of that kind of journey I've often travelled through. One thing that and again, speaking from experience, is, and you did touch on it, clearly nobody wants to spend more time in hospital than is clinically necessary. Hospitals are places. I mean, my own mum went in 2020 with a fall, and 10 days later I got a call to say she had COVID. After 8 months of keeping her very, very, very clear. It was, but the staff were absolutely brilliant over that journey, over that 1,000-day journey, or however long it was. There were many instances where, if I hadn't been involved and been engaged and to some extent been knowledgeable, my mother would have been admitted for fairly trivial things, often UTIs, often, oh, she's running a bit of a temperature, this. And the carers do a fantastic job. Obviously, some of them have got varying degrees of medical expertise, but they're not medics. But they pick up an awful lot, especially the more experienced ones who've been around the mill a few times. But I am aware that obviously they've got their professional backsides to protect in a positive way, and they will always err on the side of caution. And sometimes, if the right person is there to advocate, whether it be a medical person that that can almost put that kind of circuit breaker in before the ambulance, because once the ambulance is called, they're going in. You've got the cost of the ambulance, you've got somebody going in, and they're going to be in hospital for 1 day, 2 days, 3 days a week, and all the associated paperwork and cost with that. Whereas often, if the right intervention is done early on and the right judgment call is made, you can say, let's give it 24 hours or 48 hours when that's the right thing to do. And I'm just mindful that if for patients who have, whether it be concerned friends or relatives, or have the mental capacity themselves to make that judgment call, they can have a very different pathway. And I think one of from seeing the people that were in hospital on the various wards when my mum was in, there are a lot of people there that clearly don't have anybody advocating for them, don't have anybody that is able to stand in and make those decisions. And I think one of the things that will, and I really welcome this programme, but I think one of the things that will really make or break it in many ways is how those who don't have, kind of sharp-elbowed relatives or friends or themselves to step in and make some of those calls kind of end up flushing into the system. And I don't know whether we were fortunate and we had really, really amazing GP surgery in Seacroft that kind of stepped in, and they'd send somebody out on the same day often, and often that GP stepping in saved a hospital admission, because they could come out, check the vitals, the care team would calm down, and we'd move on, and 24, 40 hours later the situation passed. So I think two things. One, somebody needs to advocate for those that can't advocate for themselves, or have an advocate network that is non-clinical. And two, the integration, because the integration and the training that exists between the care workers in the community, which is variable, but in many cases excellent, but in some cases not great, and the GP networks to hold together so that the system works overall in the most efficient way. I don't know if there's anything you want to kind of add to that, but that's my piece.
I can respond to that. I mean, it absolutely resonates, and thanks for sharing your story about your mum. It sounds like a really difficult time, and especially with her having COVID, and that must feel really avoidable. And we absolutely recognise that your experience you wouldn't be alone in that experience. And one of the things that we have been focusing on is supporting our colleagues in the care homes to keep our patients in those really familiar environments where they're safe and much more settled often than kind of destabilising everything for them. One of our most successful programmes of work actually is the PCAL advice line. You may have heard of the primary care advice line, and I presented that to national NHS England colleagues a couple of weeks ago, and they were blown away by the success of our PCAL service, which is pretty much unprecedented in the country, because we now have 27 specialties in LTHT who are able to have a three-way conversation at the patient's bedside with their GP and the hospital consultants. And what we're trying to do now, and what we have been doing, is accelerating that out to our YAS colleagues. So for examples like yours, where one of our patients is perhaps in a care home, they've called an ambulance. There's now a facility where the paramedic can call into the hospital and have a conversation with an elderly consultant or a gastroenterologist, with a clinical team, where the three people on that call decide what the best plan is for the patient. And certainly the focus there is keeping patients at home, or linking up with what Sam's referenced, the urgent care response team. One of the 10 pillars of those services are things like catheters and falls and things that are really common presentations to hospital, where we know that actually the majority of those patients could probably stay where they are. So we've got that service in place. We're accelerating it through winter. We're building out comms and awareness through our paramedic team so that they know they can access that. And what we're trying to do is stretch that out so that the hours match when our patients' needs are, because we know that sadly a lot of the time the falls, the problems are in the early hours of the morning, when if you're a care home, if you're a carer, you haven't really got an option but to pick the phone up, because there's just no safety net for you.
Let's come in about the people who don't have any family support. So this is an area that we've recognised, and we have commissioned the third sector to provide what we call proxy family. So from a community services point of view, we're working with people who had family around them, and we were ready to discharge them, and their family would say, it's okay, if anything should happen, we'll get in touch. But the whole cohort of people who don't have that support, and so we have commissioned the third sector to be exactly that, to work with general practice, to work with the community teams, to say, I'm working with Mrs. Jones, and I want you to know this, kind of the escalation, so we can get out there really quickly before there's the need for ambulance and so on. So we're in the second year of that, and we're evaluating it to see what difference it has made. Again, we can share that with you if that's of interest.
Good, thank you very much. I can't see anyone else indicating, so I'm going to close that item. Thank you very much for coming. Really good to see you're excited and passionate about this programme, which hopefully will deliver as hoped. So thanks for your time. Okay, we're going to move on to item 10, which is work programme. So I think everyone who's not a board member is free to go now if you want to. Okay, so hopefully members have had a look at it. I don't think there's anything particular to stress. I think there's we've got a working group on children's neurodiversity and one on dentistry, which Angela will send invitations to in due course. Are there any comments or questions or items members want to raise in the work programme? Can't see anyone indicating. So with that, I'll formally close the meeting. I'd like to say thank you to everyone for attending. I think we've had a really good meeting today, really productive. So thanks for your time and see you next time. Goodbye.